Bismillahirrahmanirrahim. I am Dr. Farah Javed and today we are going to discuss about CNS stimulant drugs. The learning objective of this lecture: at the end of the lecture, students should be able to discuss the classification of CNS stimulant drugs, to explain the basic and clinical pharmacology of CNS stimulant drugs. Central nervous system stimulants are medicine that speed up physical and mental processes. Central nervous system stimulants are used to treat conditions characterized by lack of adrenergic stimulation, including narcolepsy, neonatal apnea, and attention deficit hyperactivity disorder. CNS stimulant classified into psychomotor stimulants and hallucinogen. They are classified according to their action. Psychomotor stimulants causes excitement, euphoria, decreased feeling of fatigue, increased motor activity. Example: methylxanthine, caffeine, theobromine, theophylline. Nicotine, cocaine, amphetamine, atomoxetine, modafinil, methylphenidate. Hallucinogens causes profound changes in thought patterns and mood. Example: lysergic acid, diethylhamide, phencyclidine, tetrahydrocannabinol, and rimonabant. What are stimulants? These are chemical structures similar to monoamines neurotransmitters. All are indirect acting sympathomimetics. Many CNS stimulants release catecholamines, therefore, their effects are obliged by prior treatment with respirin or guanethidine. Example: amphetamine, dextroamphetamine, methamphetamine, methylphenidate, ephedrine, pseudoephedrine, and tyramine. Other CNS stimulants block the reuptake of catecholamine and serotonin. Example: cocaine and modafinil. Therapeutic indication of CNS stimulants are obesity, attention deficit hyperactivity disorder. It is the lack of ability to be involved in any one activity for longer than a few minutes. Narcolepsy. It is a relatively rare sleep disorder that is characterized by uncontrollable bouts of sleepiness during the day. It is sometimes accompanied by catalepsy, a loss in muscle control, or even paralysis brought on by strong emotions such as laughter. Contraindication of CNS stimulants are anorexia, insomnia, asthenia, psychopathic personality, a history of homicidal or suicidal tendencies. Psychomotor stimulants are methylxanthine, nicotine, cocaine, amphetamine, and methylphenidate. Now, the methylxanthine compounds, they are adenosine receptor antagonists. Drugs within this class are not generally considered psychomotor stimulants, but they have distinct stimulant effects like caffeine and theophylline. Methylxanthine compounds are theophylline, which found in tea, long-acting and prescribed for nighttime asthma, then theobromine found in coca, then caffeine, a short-acting, the most widely consumed products, found in coffee in 200 mg per cup, carbonated soft drinks in 60 mg per can, and also found in coca and chocolate. The mechanism of action of methylxanthine, they having a multiple mechanism. It inhibits phosphodiesterase enzyme and increased cyclic AMP, which causes increased calcium in CNS and heart and decreased calcium in smooth muscles. They act as adenosine A1, A2, and A3 receptors antagonists and having many of its cardiac effects. A2 receptors antagonist responsible for CNS stimulation and smooth muscles relaxation. A pharmacological action on CNS, they decrease fatigue, increase alertness by 100 to 200 mg caffeine in 1 or 2 cups of coffees. Anxiety and tremors by 1.5 gram of caffeine in 12 to 15 cups of coffee. Cause spinal cord stimulation by 2 to 5 gram. It is a very high dose. Also cause tolerance, which can develop rapidly. Withdrawal symptoms are feeling of fatigue and sedation. On CVS, at high dose of caffeine cause positive inotropic and chronotropic effect on the heart. The diuretic action, mild increase in urinary output of sodium, chloride and potassium. On gastric mucosa, all-methylxanthine stimulates secretion of HCl. On respiratory smooth muscles, they cause bronchodilation and used as treatment of asthma. Pharmacokinetic of methylxanthine, they are well absorbed orally. Caffeine distributes throughout the body, including the brain. The drugs cross the placenta to the fetus and it's secreted into the mother's milk. All are metabolized in liver and the metabolite are then excreted in the urine. Adverse effects at moderate doses cause insomnia, anxiety, and agitation. At high doses cause emesis and convulsion. At lethal dose, that is 10 gram of caffeine, cause cardiac arrhythmia. When suddenly stopped, cause lethargy, irritability, and headache. Now the nicotine. Nicotine is the active ingredient in tobacco used in smoking cessation therapy. Nicotine remains important because it is second only to caffeine as the most widely used CNS stimulant and second only to alcohol as the most abused drug. The mechanism of action of nicotine at low doses, nicotine acts as ganglionic depolarizer. At high doses cause ganglionic blockage. The pharmacological action of nicotine, first on CNS, at low doses cause euphoria, arousal, relaxation, improves attention, learning, and problem solving, and decreases reaction time. At high doses cause CNS paralysis and severe hypotension. The peripheral effect of nicotine, the stimulation of sympathetic ganglia and adrenal medulla, cause increase in blood pressure and heart rate. The stimulation of parasympathetic ganglia by nicotine cause increased motor activity of the bowel. At higher doses, nicotine cause decrease in blood pressure and inhibition of GI and bladder muscles. Adverse effects are irritability and tremors, intestinal cramps, diarrhea, increased heart rate, and blood pressure. The withdrawal syndrome by nicotine, basically the nicotine is an addictive substance, so the physical dependence on nicotine develops rapidly and can be severe. Bupropion can reduce the craving for cigarettes, transdermal patch, and chewing gum containing nicotine available, that is, Varenicline. Varenicline, partial agonist at nicotine receptor in CNS. It produces less euphoric effect than those produced by nicotine itself. Thus, it is useful as an adjunct in the management of smoking cessation in patients with nicotine withdrawal symptoms. Now the cocaine, highly addictive drug. The mechanism of action is to they block the reuptake of monoamine, thus potentiate and prolongs the CNS and peripheral action of these monoamines. Initially produces the intense euphoria or rush by prolongation of dopaminergic effects in the brain's pleasure system, that is limbic system. It is this immediate positive reinforcement followed by rapidly negative reinforcement that makes the drug specifically in this form so addictive. Chronic intake of cocaine depletes dopamine. This depletion triggers the vicious cycle of craving for cocaine that temporarily relieves severe depression. The mechanism of action of cocaine, basically Ritalin and cocaine both blocks the dopamine transporter causing dopamine to build up in the synapse. Cocaine has minimal bioavailability when taken by the oral loads. Instead, the cocaine hydrochloride powder is snorted or solubilized and injected. The cocaine powder cannot be effectively smoked as it is destroyed upon heating. However, crack cocaine and alkaloidal form can be smoked. The pharmacological action of cocaine, first on CNS, cause behavioral effect result from powerful stimulation of cortex and brainstem. Cocaine acutely increases mental awareness and produces a feeling of well-being and euphoria similar to that produced by amphetamine. Like amphetamine, cocaine can produce hallucinations and delusion of paranoia. Cocaine increases motor activity and at high doses it causes tremors and convulsion followed by respiratory and vasomotor depression. On sympathetic nervous system, they peripherally potentiate the action of norepinephrine and cause fight or flight. Hypothermia, they impair sweating and cause cutaneous vasodilation and decrease perception of thermal discomfort. Also act as local anesthetic because they cause blockage of voltage activated sodium channels. Cocaine is the only local anesthetic that causes vasoconstriction. Chronic inhalation of cocaine powder causes necrosis and perforation of the nasal septum. Cocaine is often self-administered by chewing, intranasal snoring, smoking, or intravenous injection. Adverse effects are anxiety reaction that includes hypertension, tachycardia, sweating. Because of the irritability, many users take cocaine with alcohol. A product of cocaine metabolites and ethanol is cocaethylene, which is also psychoactive and causes cardiotoxicity. Depression, like all stimulant drug, cocaine stimulation of the CNS is followed by a period of mental depression. Addict withdrawing from cocaine exhibit physical and emotional depression as well as agitation. The latter symptoms can be treated with benzodiazepine or phenothiazines. The toxic effects are seizure treated by IV diazepam and fatal cardiac arrhythmia treated by propranolol. Now methylphenidate. It has CNS stimulant properties similar to those of amphetamine and may also lead to abuse, although its addictive potential is controversial. The pharmacologically active isomer and has been approved in the USA for the treatment of ADHD. The methylphenidate is a more potent dopamine transport inhibitor than cocaine, thus making more dopamine available. It has less potential for abuse than cocaine because it enters the brain much more slowly than cocaine and does not increase dopamine level as rapidly. Now, amphetamine. It is a non-catecholamine. Dextroamphetamine is the major member of this class. Methamphetamine is a derivative of amphetamine that can be smoked and is preferred by many abusers. Methylene deoxymethamphetamine is a synthetic derivative of methamphetamine with both stimulant and hallucinogenic properties. The mechanism of action of amphetamine, they act by releasing intracellular stores of catecholamine and also inhibits MAO. High level of catecholamine are readily released into synaptic spaces. The pharmacological action first on CNS due to combination of its dopamine and norepinephrine release enhancing properties, amphetamine stimulates the entire cerebrospinal axis, brainstem and medulla. This leads to increased alertness, decreased fatigue, depressed appetite and insomnia. Sympathetic nervous system indirectly stimulating the receptor through norepinephrine release. Adverse effects are addiction, dependence, tolerance, and drug seeking behavior. On CNS, insomnia, irritability, weakness, dizziness, tremor, hyperactive reflex, confusion, delirium, panic states, and suicidal tendency, especially in mentally ill patients. Chronic amphetamine use produce a state of amphetamine psychosis that resemble the psychotic episodes associated with schizophrenia. Overdoses. They are treated with chlorpromazine or haloperidol, which relieve the CNS symptoms as well as hypertension because of their alpha blocking effect. The anorectic effect of amphetamine is due to its action in the lateral hypothalamic feeding center. Adverse effects on CVS are palpitation, cardiac arrhythmia, hypertension, anginal pain, circulatory collapse. Headache, chills, and excess sweating may also occur. On GI are anorexia, nausea, vomiting, abdominal cramps, and diarrhea. The contraindications are hypertension, cardiovascular diseases, hyperthyroidism, glaucoma, patient with a history of drug abuse. Narcolepsy, amphetamine, methylphenidate, and recently a new drug, modafinil and armodafinil, have become available to treat narcolepsy. Modafinil produces fewer psychoactive and euphoric effect as well as alteration in mood, perception of thinking and feeling like other CNS stimulants. Atomoxetine, approved for ADHD in children and adults. It is a norepinephrine reuptake inhibitor. It is not habit forming and is not a controlled substance. Now, hallucinogens. These are lysergic acid diethylamide, tetrahydrocannabinol, and phencyclidine. The first is lysergic acid diethylamide. Multiple sites in the CNS are affected by LSD, inhibit the firing of serotonin containing neurons in the RAF nuclei, probably by stimulating serotonin inhibitory autoreceptor on these cells. Activation of the sympathetic nervous system occurs, which causes pupillary dilation, increased blood pressure, and increased body temperature. Lysergic acid diethylamide has no therapeutic uses. Adverse effects are hyperreflexia, nausea, and muscular weakness. High doses may produce long-lasting psychotic changes in susceptible individuals. Haloperidol and other neuroleptic can block the hallucinatory action of LSD and quickly abort the syndrome. Now, tetrahydrocannabinol, the main psychoactive alkaloids contained in marijuana, is tetrahydrocannabinol, which is available as dronabinol. THC can produce euphoria followed by drowsiness and relaxation. The effect of marijuana on GABA in the hippocampus diminishes the capacity for short-term memory in users. They decreases muscle strength and impairs highly skilled motor activity, such as that required to drive a car. Its wide range of effect includes appetite stimulation, visual hallucinations, delusion, and enhancement of sensory activity. The mechanism of action of THC, basically the THC receptors designated CB1 receptor, have been found on inhibitory presynaptic nerve terminals. CB1 is a couple to a G protein. Endocannabinoids have been identified in CNS. These compounds, which bind to the CB1 receptors, are membrane-derived and are synthesized on demand, and they may act as local neuromodulators. This figure shows the working of cannabins. Basically, the endocannabinoids, brain-derived, phytocannabinoids, plant-derived, and synthetic cannabinoids, pharmaceutical-derived. They all bind to endocannabinoid receptors in brain and the endocannabinoid system is involved in regulating a variety of physiological processes, including appetite, pain, pleasure sensation, immune system, mood, and memory. The mechanism of action of cannabinoids. The first excitation of postsynaptic neuron causes its depolarization and influx of calcium. Then elevated level of calcium stimulates the synthesis and release of endocannabinoids. These endocannabinoids bind to cannabinoid receptors on presynaptic neurons that form synapses with stimulated neurons. And then activated receptor modulate the release of inhibitory neurotransmitters such as GABA. Therapeutic uses of dronabinol as an appetite stimulant for patients with acquired immunodeficiency syndrome who are losing weight. It is also sometimes given for the severe illnesses caused by some cancer chemotherapeutic agents. Adverse effects are increased heart rate, decreased blood pressure, and reddening of conjunctiva. At high doses, a toxic psychosis develops. Tolerance and mild physical dependence occurred with continued and frequent use of the drug. Now the rimonabant. Rimonabant, the CB1 receptor antagonist used in obesity to decrease appetite and body weight in humans, but induce psychiatric disturbance such as anxiety and depression during clinical trial. Now the last one, phencyclidine, also called angel dust. They inhibit the reuptake of dopamine, serotonin, and norepinephrine. The major action of phencyclidine is to block the ion channel regulated by NMDA subtype of glutamate receptor. This action prevents the passage of critical ion through the channel, that is calcium ion. Phencyclidine also has anticholinergic activity but produces hypersalivation. Phencyclidine is an analog of ketamine, causes dissociative anesthesia and analgesia. At increased dosage, they cause anesthesia, coma results, but strangely, the eyes may remain open. Increased sensitivity to external stimuli exit, and the CNS actions may persist for a week. Phencyclidine has no therapeutic application and manufacture of the drug is illegal. These are basic cues for your self-assessment. Thank you for listening me.